All right, officially recording. I just have a few opening slides I want to kick off the discussion with and help frame. Some of these things will be echoed by our other presenters. First, I love this quote from Dr. Bugsevic, who shared this in the context of COVID at the CROI meeting last year. But I think it's absolutely, of course, germane to what we're talking about. And that is this idea that people are not the drivers of transmission. Rather, it is their unmet needs. And as you look at those little images of the unmet needs, you will note that they are all what we would call social determinants of health. And also just want to put out there, this is a very US focused webinar today. So we're going to be very US centric, and this is a simplified diagram of the US healthcare system. This is sort of what it looks like. Simple, easy, no problems, right? This here is just one issue that we face in terms of how we deliver PrEP equitably. We have a healthcare system that is absolutely crazy. And navigating it is filled with friction and feels like burrs and brambles and trying to walk your way through a thicket without a map. My final comments, I want to focus in on equity and justice. And so some people may recognize this image from The Giving Tree, a famous short book by Shel Silverstein from the 60s, back when I was just a baby. So let's look at these images. This first image is inequality. And we can all agree that this is the case in so many places, but this is not something that we want. Now, equality tends to be something that we praise and that we get excited about. Certainly in the United States context, equality seems to be everything. But in fact, equality also ain't great, right? These people each have the same they have the same tree, and they have ladders, the same size ladders to get to that tree, but one person's ladder is wholly inadequate and one person doesn't have anything to collect those apples with. And finally, the tree is tilted to one direction. So now we're getting places. This is what equity looks like. Equity means that everyone has access to that tree, actual access, with appropriate tools to help them get those apples. So the right size ladder, they each have a bag to collect those apples. So we're getting there, right? Are we done though? Are we done with equity? I would say we're not. I would say this is what we're going for: justice. So justice means we not only give people the tools that they need to access resources, in this case, apples, but we change the systems and structures that favor one group over another. You notice that that tree now is standing upright. It is no longer bending to one side and favoring one group of people. And I'll just say it, in the United States, the tree bends to the side of white people and it favors white people and it disfavors everybody else. So justice means changing systems and structures. I would suggest justice means reparations. Justice means redistribution of resources based on priorities around need and not around equality. That's what equity and justice is. So boo on inequality, actually boo on equality. We're getting there with equity, but let's talk about justice today. So when you all registered, we asked you some questions, and we asked, one of these was, what ideas do you have to address PrEP inequities? And there were so many great things that you shared. So I'm not going to read all of these, but I'll let you kind of take them in. But you'll see everything from focusing on communities of color to prioritizing allocation of resources, centering pleasure, increasing providers and clinics that deliver PrEP, dismantling racism, and rolling out a national PrEP program. We're not content with these sort of fake donations from pharmaceutical companies and access programs that are limited in scope and hard to manage. So we heard from so many people. Thank you so much for sharing your ideas. Also, thank you for sharing your questions. All your questions were shared with the presenters. So hopefully we'll be able to address them in our talks today. And if not in the talks, hopefully during the robust conversation that we hope to be having throughout this webinar. I'm not going to belabor this. We'll drop in the link that you can go here directly in case you can't use your camera to take a snapshot of that URL. So Jason will drop a link in there. But Michael will be talking about this, and I imagine Leisha will be as well. And then another thing I'm not going to belabor, but I just want to highlight, because it will be discussed by some of our other presenters, but PrEP in Black America version 2, or number 2 in the series, is coming very soon in just 10 days. And you can register either online for virtual participation, and I believe they're still taking registrations for in-person. And Michael and Leisha will tell us more about that, I'm sure. So without further ado, I want us to go ahead and get started. I'm going to stop sharing my screen, and I am going to invite our first speaker, who is Dr. Patrick Sullivan from Emory University. Has been working a great deal in the PrEP space and measuring equity and inequity, and he's going to kick us off today. I'm going to go ahead and turn it over to you, Patrick. Thank you so much. And Patrick, if you're speaking, you're on mute. And Patrick, are you having issues unmuting yourself? Yes. Okay. So while Patrick is managing some technical issues, and you know, these things happen, that is the world of Zoom. We are willows and we will bend, we will not break.
Got it.
Oh, there we go. I'm done vamping. We have, we've got audio. Go ahead, Patrick, take it away.
Great. Thank you so much. And thank you for the introduction and for the opportunity to be here today and be part of this conversation. I'm Patrick Sullivan at Emory University, and I want to talk today about, Jim, what you introduced on the equity piece, which is how do we measure equity? How do we know in the context of PrEP that we've reached equity? And what are the consequences if we do or don't reach equity? I want to disclose that I have research grants and consulting fees from Gilead, Merck, and grant funding from ViiV. So the folks on this call will appreciate that PrEP was approved over a decade ago, and Black and Hispanic people in the US have higher rates of new HIV diagnoses than white, non-Hispanic folks in the US. People in the US South have more risk of HIV infection than people in other regions. And to really take what Jim talked about in terms of health equity and bring that into practice, it means that access to and use of prevention interventions needs to be in proportion to the impact of the health concern. In other words, folks who have a greater risk of HIV infection should have greater access and greater use of PrEP that's in proportion to that increased risk. So I just want to talk a bit about how we measure our success and opportunities towards equity and how our currently and how we should be measuring them. So sort of one way that that people think of to measure progress in an intervention like PrEP is to think about the percent of people, for example, with PrEP indications over time. And as the intervention rolls out, we'd like to see that a higher and higher proportion of people with PrEP indications are actually receiving PrEP. We can set goals to increase, PrEP coverage over a certain period of time. But Jim already set this up nicely. I mean, this kind of thing, if we look, for example, comparing these metrics in the South or between Black and Hispanic and white folks in the US, we're really looking at equality metrics. Is everybody getting the same? And as Jim pointed out, what we want is a situation where everybody gets the thing that they need to achieve an equitable health outcome. So my colleague Aaron Siegler from Emory came up with an equity metric indicator called the PrEP to need ratio. So instead of just looking at the number of PrEP users in a group, Aaron suggests that we look at the number of PrEP users divided by the number of new diagnoses in the same year in that group. And look at how this, we're going to talk more about flipping the script, but this flips the epidemiologic script. Because if you just look at the prevalence of PrEP use in the United States, this is for 2017, where darker green indicates sort of higher proportion of people using PrEP, you might say, well, the South is not doing that badly. Florida looks like it's doing great. Georgia's doing pretty well. But if you look instead at the sort of equitable use of PrEP, in other words, we know that the South has many more new HIV diagnoses, much more risk. So PrEP use should be much higher in the South. And when we look at an equity metric, it really shows us just how badly the South is performing compared to other parts of the US. So using the right metric, a metric that says that more PrEP is needed in groups that have more diagnoses or more risk, really changes the conversation and illustrates where we have work to do. It's possible to change this circumstance. And so in another kind of natural experiment, just asking, how does that measure of PrEP equity do in states that have neither PrEP-DAP or Medicaid expansion? One of those two, the PrEP to need ratio, remember higher here is better, are more equitable. The PrEP to need ratio is higher if states have either PrEP-DAP or Medicaid expansion. States that have both PrEP-DAP and Medicaid expansion have PrEP to need ratios that are double. So I think what this says is that policy in demonstrable ways leads to increased equity. When we break this down and look by region and race, we see the same pattern in all four of the regions, and I'll walk you through this quickly because I think it's a major gap that we need to address. So one overall conclusion, these lines are PrEP to need ratios. Remember that higher is better, higher is more equitable within that group. So the purple line, first observation is that in every state, in every region that we looked at, the South ends up in all racial ethnic groups with the lowest PrEP to need ratio, the lowest equitable use. In every group that we consider, the Northeast ends up with the highest equitable use. And then within each region, we have another pattern, which is that the white specific PrEP to need ratio is the highest. The Hispanic PrEP to need ratio is intermediate, and the Black PrEP to need ratio is lowest, and that's true across every region. So why is this happening? It's because across the United States, Black people have a higher risk of HIV. So even if we get relatively equal levels of access, that's still going to be much less than is needed in Black and Hispanic communities in the South, for example, because of higher risk. And the other thing I think that's important to look at over time is that this blue bar in the Northeast here represents essentially the extent of the inequity, the gap between what's happening in for white residents in the Northeast and for Black and Hispanic residents. And over time, the length of that bar actually gets bigger. So as we've been rolling out PrEP, the inequities are actually growing rather than shrinking. Another way to picture this is to say that ideally the PrEP to need ratios would be equal for Black, white, and Hispanic people. And in fact, what has played out is that for Hispanic people, these sort of equitable levels of PrEP use are about 75% lower than for white people in the US. And among Black and Hispanic, or I'm sorry, among Black residents in the United States, these equitable levels are about an eighth of what would look like equity. So the point here is that these gaps in equity are profound, and they're likely to lead to growing or diverging paths in new diagnoses, because we're just not getting PrEP to the people who will benefit most. We can also look at this by sex, and these are PrEP to need ratios starting when PrEP was introduced. And over time, you can see that that although men as a group have greater risk, their relative uptake of PrEP has actually outpaced even that greater risk, and we're left again with this widening equity over time, equity gap between men and women. If we use that same sort of depiction, since 2014, women have been underserved by PrEP relative to their epidemic need, about 60% underserved. And so there's also a substantial gap here. So I just want to sort of think about a minute what happens if we allow this sort of inequitable use of PrEP to continue, because it really has consequences in what's going to happen in the epidemic in the future. So if we sort of look at these data from William Godel and say this has to do with describing what happens when you have a PrEP to need rate, that gap, that PrEP equity gap of tenfold. And this, in this particular example, is focused on Black and white men who have sex with men, but the same principles hold. And so essentially, if we have a situation like this, where, for example, in Black, if we had an equal PrEP to need ratio, 5 for Black men who have sex with men, 5 for white men who have sex with men, that would represent sort of an equitable distribution of PrEP. Everybody's getting PrEP in proportion to their epidemic need. And when that happens, these green shades mean that the disparities in HIV incidence, the excess cases and infections that are occurring in Black Americans, that disparity in incidence goes down. So if we can serve everyone equitably with PrEP, we're actually going to reduce the gap in excess diagnoses in Black gay and bisexual men. And in fact, in much of this chart, even aside from like strict equity, if Black men actually perform better with respect to PrEP equity, we get even deeper green, bigger reductions in that gap in incidence. And there's only a few places in this whole chart where we could actually make the disparities in new infections worse, where we could actually widen the gap between Black and white MSM. And those are these boxes right here. And according to the data that we have, where we are is right about here. So currently we are inequitably distributing PrEP. And what models predict is that if we keep doing that, we're just going to see the gap in new infections widen even more, such that Black gay and bisexual men, Black Americans more generally, are going to be more disproportionately impacted in the context of PrEP use. And to change that, we need to get back to this line, which is PrEP to need ratios that are equal in the groups. So how can these metrics make a difference in public health programs? I feel like PrEP equity metrics should be our primary measure of the success of programs. I think the first intuition is always to look at how many people have we gotten onto PrEP as a system, to maybe even to ask, are we getting the same proportion of Black and white, of men and women, of people in the South and Northeast onto PrEP? But that's again an equality metric. I think we need to be focusing equity metrics as the primary measure. And if we program to equity metrics, we start asking ourselves, what could we do with our money that is going to differentially benefit the groups who have deficits in equity? That means the South, that means women, that means Black Americans, that means Hispanic Americans. And so this needs to be done at the local level. So I've shown you a lot of national, some regional. This really needs to be done in every health jurisdiction. And the reason for that is that we won't succeed as a country in achieving and meeting some kind of equity goals unless every state is succeeding, unless every jurisdiction within that state is succeeding. We won't be able to achieve success nationally. And national equity will come from a sum of local success and equity. And to do that, we need to be having these same conversations, looking at these same graphs for your jurisdiction, for your state, for your MSA, and changing program in response to that. So how should we be guided by equity? We need to use equity metrics rather than equality metrics. By this measure, US prevention programs in every region are failing and demonstrate actually decreasing equity over time. The South lags the other regions, women lag and compared to men. We need to think about how programs can be constructed that provide PrEP to communities and the people who are at greatest risk from HIV infection, or another way to say that is who are most likely to benefit from PrEP. And ecological data have already shown that policy interventions can make a difference. Considering Medicaid expansion for states that haven't done it, considering PrEP programs, discussions of a national PrEP program, things that will lower those bars. And I think Jim really set up nicely with the slide about what those social determinants of health are. Their out-of-pocket costs, their travel distance to providers, their stigmas that prevent people from seeking or being or staying on PrEP. And so we need research, we need policy, we need programs that address those barriers. So this is work of a large group of people. They're listed here. Dawn Smith did this work that you see today with us, and we acknowledge her with gratitude and respect. We miss her voice greatly. Thank you.
Thank you, Patrick, so much for really laying this out beautifully. And I know our next two speakers will be bringing forward some ideas for addressing and flipping the script from inequity to equity and justice. But I just I have a quick follow-up question, and then if anyone wants to raise their hand and do a quick follow-up question, we have a moment or two. But Patrick, if you could just explain for everyone, not everyone may understand, what is the situation in the United States in that Black gay men are so much more vulnerable to HIV than white gay men? Is it because Black gay men are engaging in more behaviors that put them in that level of vulnerability, or can you just describe what's going on there?
Yeah, thank you so much for that question, because it's not doesn't have to do with higher levels of sex, or I'm going to put in air quotes for people who are on audio only, of risky sex. And I think it's a real problem to suggest that this is because of behavioral choices. This is because of inequitable systems, unjust systems, less access to healthcare, greater experiences of stigma, and also the way that sexual networks are shaped, and because of historical segregation, discrimination, that the partners of Black, gay, and bisexual men may be more likely to be living with HIV, may be more likely to be living with undiagnosed HIV. So the solution to this particular thing is first to say that there's nothing wrong with the way that Black gay men are having sex, and that the system has failed to provide protections equitably. And that, again, that's just based on geography, where treatment places are located, access to health insurance, et cetera. There are also higher rates of sexually transmitted infections in some communities of Black, gay, and bisexual men, again, solely related to inequitable provision of prevention services and prevention commodities. So I think that's a really important context. And really what we're talking about with PrEP inequity is just a furthering of that. We're saying that these disparities are with us at the start because of inequitable access to healthcare. And if we don't want to make the same mistake twice with the prevention mode. So that's why we need to be asking, whether we're serving in proportion to risk. Risk meaning epidemiologic risk, not that behaviors we're equating behaviors with risk, but what is my chance of getting HIV? And if that's high, then I need to be a priority for access.
Thank you so much for beautifully explaining that. And I have one more quick, maybe, potentially a conversation that we'll have later when Michael and Leisha are finished up with their remarks. But we talk about PrEP furthering, PrEP has been furthering disparities, and I have great concerns about the new version of PrEP, injectable PrEP, just taking those disparities and turbocharging them. There's so much excitement about this shiny new modality, only 6 shots a year, yada, yada. But I have great concerns about whether or not this is actually gonna do anything to achieve better equity. Do you have any thoughts on that you'd like to share?
I think it depends. It depends on whether we can continue to make the same inequitable, efforts to serve people who need HIV protection, HIV PrEP most. And what I would say is that in theory, an injectable agent that requires less trips, that mitigates some of the concerns about stigma of holding pills. Like I think we all have heard and talked to people who don't bring their PrEP bottle with them because they fear that it would be spotted, and either people would know they're on PrEP, which is a stigma, or people would assume they're living with HIV. And so I think in theory, a long-acting injectable should be able to address some of the things like how long it takes to get to the doctor's office, for example, if you have to go less often. Stigma associated with picking that medication up at your local pharmacy, having the pill bottle. Some of those things actually have the potential to decrease those stigmas, but it's sort of going to come down to whether the rollout really allows, again, people who are most likely to benefit from this tool to access it locally, conveniently, at an appropriate, cost structure. And so I think the tool itself, tools are nothing but good. How they move equity has to do with how we roll them out. And so let's ask those questions up front about how we can make sure that it's not the people who are already best insured, best supported, and sort of most engaged with healthcare who get that sort of next new tool, which holds a lot of promise and holds equity promise if we do it right.
Right on. Thank you for that. And I think we could probably dive in deeper on that later. So thank you, Patrick, though, for a great talk and really great information for all of us to chew on. Without further ado, I'm going to ask my good friend and colleague, Leisha-McKinley Beach, to go ahead and take the virtual podium, share your screen, and show us your stuff, my friend.
All right, let's see here. Okay, are you able to see my slides, Jim?
They look gorgeous. Thank you, Leisha.
Okay, awesome. So good morning, everyone. And I just want to make sure that you all are still awake with me. If so, I would like to see an emoji giving credit to our DJ Jazzy Pickett for the great music this morning. Okay, Patrick, I see you still with me. All right, awesome. What I appreciate so about Dr. Sullivan going first and framing the discussion on this morning is looking at the data trends. And if we continue on this same path, what the outcomes will be. And so I would like to take a few minutes and talk specifically about Black communities and looking at a perspective of if we begin to shift both in framing conversation and access to PrEP resources, what that looks like, how this shift begins, and could we see the tide change? I first want to acknowledge someone who is near and dear to many of us, and that is the late Dr. Dawn Smith. Dr. Smith had a conversation with me months before she passed away. And she said something that at the moment, I had no idea that would become the foundation of what we now know as the PrEP in Black America convenings. Her comments were that when we look at PrEP in the United States and the lack of uptake of PrEP amongst all Black subpopulations, meaning Black same gender loving men, Black cisgender women, Black people of trans experience, none of us are faring well in terms of PrEP uptake. So although there is a needed space to be addressing these subpopulations separately because some of the issues are different, but we also got to acknowledge that some of these barriers and challenges are the same by nature of race. And so are we doing our community a disservice by not having that space to address Black issues with PrEP? And that conversation led to the beginning of the convening of PrEP in Black America. And so when you hear us talk about PrEP in Black America, and of course, Michael is going to go into greater detail about it, know that Dr. Dawn Smith's vision is still alive through these convenings. I want to encourage folks to download these 3 reports. These reports, We the People, A Black Strategy to End HIV, Black South Rising, The Future is Now, and then For Us, By Us, PrEP in Black America. These 3 reports in particular are reports that I use in terms of looking at what the barriers and challenges are. They've already been framed. So we don't need to continue to discuss what those are, but what we need to put our efforts on is looking at what are some solutions or recommendations to how we address those barriers and challenges. And I'm going to take some time this morning and talk about each of these reports, but I'm going to ask you at this moment that instead of looking at the barriers or challenges or recommendations globally, I'm going to ask you to look at it through 2 lenses. Lens number 1 is, what is your agency, coalition, whatever entity that you are connected with? What are your contributions in addressing some of the highlights that we're going to discuss? And then the second lens is, what am I as the individual? What am I doing? What is my contribution to contributing to ensuring equity? And as Jim so eloquently stated this morning, to what justice framing looks like as it relates to PrEP. Some of you, of course, know Rania Copeland. She is the founder of Equity and Impact Solutions. But before Rania started her own firm, she served as the CEO of the Black AIDS Institute. And during her tenure, Rania created this report, We the People, a Black strategy to end HIV. And in the report, this issue-based report took a look at several key areas that were already discussed this morning with Patrick. And I just want to highlight two for this conversation. One is, let's look at those practices, the systems, and the institutions that endanger the health and well-being of Black people. And those issues, those systems, those institutions, those are those barriers for us to achieving an equitable response to HIV.
Hey, Leisha, I think you may have frozen up. Yeah, I think Leisha's frozen. I'm going to ask folks who are on their video to just go off video and see if we can help the bandwidth a little bit here. So if you're on video, can you go off video? And we'll see if Leisha can come back. Leisha, are you there? Okay, I actually think we just lost Leisha. Oh, no, I see you. Leisha, are you there?
I'm here.
Okay, we lost you for a second. I'm so glad you're back. We lost your screen, but you can go ahead and pick back up where you left off once you start resharing.
Okay, so let me do this. I know you want to see my lovely face, but I'm going to turn this off for a second and see if that helps us as well.
Thank you. We can hear your lovely voice, which is most important right now. There you go. Looks great.
Okay. All right, and so you're able to see my presentation again. Whoops.
Yep, we see it again. You just want to get into slideshow and you're set.
Okay.
There you go. Beautiful.
All right.
Thank you.
So I apologize for that. I don't know where I left off, but you've seen the highlights. And the one that I want to focus on is, what are we doing to build the capacity and motivation of Black communities to be the change agents for ending HIV? This one in particular becomes critical because we're also talking about what does it look like for Black leadership in terms of addressing PrEP in America for Black communities, and also what does it look like for folks to see themselves and feel heard as we are looking at these inequities as it relates to PrEP. The next report, Black South Rising, is a Southern coalition that has been convened by two amazing people. Charles Stevens, who is the executive director of the Counter Narrative Project, and Vanita Ray, who is also a consultant, helped to craft the report that looks specifically at the Southern geographical area and some of these challenges as it relates to Black communities. Patrick shared a slide of the gaps between access to PrEP, the PrEP need ratio for white compared to Black, and some of the issues that are contributing to that widening gap. They're addressed in this report as well. We're not talking about behaviors of individuals as it relates to their sexual health, but we are talking about these systems, these destructive systems and institutions and healthcare facilities and medical homes that are contributing to these gaps. So for example, if we're not having a conversation about how clinicians are making decisions around who they will have PrEP conversations with, that's a problem. If we're not discussing the fact that we see Black people who are visiting medical homes, including in our HIV workforce, and they're not being offered PrEP, or no one's introducing PrEP to those folks. And we've seen data that have shown that folks who have seroconverted 6 months after they had an encounter with a medical provider. And so we have to be talking about what dismantling of those destructive systems look like. Again, what does Black leadership and representation look like, and not just outreach, but in decision-making positions as well. And our funding, are those resources that are going to Black-led organizations or agencies who have centered Black communities? Is there equity in those funding resources as well? And now that we know all of these root causes, down to racism being a public health crisis, but also racism being one of those root causes as we look at HIV outcomes, including PrEP use. What are we doing, and where are those spaces where we're talking about solutions to those things? I want to highlight 9 amazing people who have served as the conveners of Black PrEP in Black America. And I know that there are 10 people there, but my country math is correct. There are 9 folks that I want to highlight. These amazing young people are researchers, they're leading HIV organizations, consulting firms addressing health equity and advocacy work. These folks all came together and are building these spaces to have conversations around the country about what PrEP looks like for our community and how. So not just those barriers, but how are we framing solutions to end that widening gap that Patrick spoke about earlier? And one of the most important components of addressing PrEP scale-up in Black communities is a national PrEP program. Now, when we think about a national PrEP program, we also have to think about some of the reasons why we don't see PrEP use at the rate in Black communities that we see in other communities, and ensure that a national program also includes those key indicators to ensure that Black people are benefiting from this effort at the rate that other communities are as well. A focus on an expansion of providers. And so these aren't providers that are just in HIV Inc. These are obstetricians and gynecologists, as we are talking about PrEP uptake among cisgender women. So that for some women, the only provider that they will see annually is their gynecologist. And so what has been our efforts in ensuring that outside of the HIV workforce, that we are focused on PrEP education, PrEP awareness, access, and scale up with these specialty providers. Marketing campaigns that don't talk about Black people, you are at risk for HIV, get PrEP now, but marketing campaigns that talk about our options and our choices and our reasons for choosing this option as a strategy for HIV prevention. I know it's hard for some people to believe, but there really are Black researchers. And we have done a poor job in uplifting research done by Black researchers for Black communities as it relates to HIV and PrEP. And so again, using that lens to say, what can I do individually to help uplift and celebrate those? What can my agency do to utilize some of this research to help us build our PrEP program? And then finally, sex positivity may look different across different genders, across different sexual orientations, including the space to allow that diversity to come through. So that as we are talking about PrEP, we're not creating more stigma for different populations, but we are creating spaces that allow folks to celebrate themselves as sexual beings. And you've already seen this slide, but you will see it again. And this is the promotion of the National PrEP program. I believe the link has already been placed in the chat. I do think that this is a moment, this is an opportunity for us to really get it right in terms of ensuring that the advocacy doesn't benefit just one group, but the advocacy and implementation of a national PrEP program benefits all communities.
Leisha, what a beautiful talk. As ever, every time I listen to you, I learn something new and am so inspired. Thank you for really a wonderful set of remarks. We have a moment to see if anyone wants to ask a follow-up question before we move on to our final speaker. We'll still have plenty of time to talk after that. But while we're kind of hanging out here, and while we still have you, you're still on screen, I can see you live and in person, yay. So Leisha, I want you to imagine, we're gonna do the elevator experiment, and you are in an elevator with the brand new head of CDC, who we don't know who it is yet. We know Rochelle Walensky is leaving, and there's gonna be a new person at CDC soon, and you get in an elevator with her or him or them, and you are going down 5 floors and you have them alone and you don't have a lot of time. What do you tell them? What are you going to say to them in that elevator about PrEP equity and doing better on PrEP in this country?
I would say to them that there will come a time when their leadership will determine if there will be a time when HIV is a part of our history. What will be their contribution to ensuring that all communities will be able to celebrate the end of the epidemic?
Beautiful. And ding, the door opens and you're off into the world. Thank you so much for that, Leisha. We're going to continue the conversation with the whole group, but before we get to that, we have one final speaker, another one of the amazing advocates who's leading the PrEP charge, PrEP in Black America, the National PrEP Program, friend and colleague Michael Chancley from PrEP for All. Michael, I'm going to invite you. You're sharing your slides. Go ahead and take it away.
Hey, okay, give me 1 second. Just trying to hit play.
So many buttons.
Right.
Beautiful. Thank you.
Good morning, good morning, good morning. My name is Michael Chancley. I am the Communications and Mobilization Manager for PrEP for All, and I am also a organizer for the PrEP in Black America Coalition. No conflicts of interest. I haven't received any corporate or pharma funding. Just a little bit about me. I am a Black gay male from the Deep South. I am a PrEP user since 2015. I feel like that's always important to let people know, especially when building trust with the community. Letting them know that I not only take PrEP, but I also encounter the same barriers like stigma and coverage issues and things like that, medical mistrust, the same barriers that they encounter when trying to access PrEP. I'm a former PrEP navigator and linkage care specialist in both New Orleans and now my new second home, Decatur, Georgia, linking over 1,000 clients to HIV prevention and care services. A writer for the body, a organizer for the PrEP in Black America Summit, and a advocate for a federally funded national PrEP program. So just a few things, some numbers about PrEP as far as it relates to the Black community. Black people represent 14% of PrEP users, but 42% of new HIV diagnosis nationally. Also, of the Black Americans who could benefit from PrEP, 91% have not received a prescription. In 2020, Black people represented 52% of new HIV diagnoses in the South, yet only accounted for 21% of PrEP users in the region in 2021. And while PrEP use has increased across all races and ethnicities, equity in PrEP use has actually decreased. So we're seeing that number widen in the racial disparity in people who could actually benefit from PrEP and are able to access it. So what are some of the barriers that lead to those disparities in PrEP utilization? So HIV stigma and lack of sex positive approaches representing the diversity of the Black community. The way you would market PrEP to Leisha may not be the same way that you would market PrEP to me. So being able to have those diverse conversations based on our backgrounds and where we're from within the Black community, our lived experiences. Mistrust of historically problematic medical systems, as well as medical biases. Gender inequity in HIV prevention research, including the lack of studies on modalities for cis women and individuals assigned female at birth. Lack of public education on interactions between hormones and PrEP for transgender individuals, and lack of medical coverage, including in non-Medicaid expansion states like those in the South. So how are we addressing that? So I'm going to show a quick video from our first summit, the PrEP in Black America Summit. Cut my volume up.
Some priorities of what a national PrEP program would need to look like in order to address the racial disparities, particularly among Black folks in PrEP access, use, adherence, et cetera, that we all know.
Nearly since the beginning of the epidemic, Black people have been disproportionately impacted by HIV in this country and globally. If we have any sort of seriousness at all about, ending the HIV epidemic, as we've been sort of talking about the last decade, then Black people have to be at the, front of the line in terms of, access to treatment and to prevention. And PrEP is a, major prevention strategy.
Today, only 9% of Black people who could benefit from PrEP are using it.
We have absolutely every tool we need now to end HIV. PrEP is one of them. And when we think about the amazing medical advances of PrEP and how Black communities could benefit greatly from it, but we're not. You have to look at the reasons why. And everything is not about personal behavior and choice. Some of this is the infrastructure and the systemic issues that Black people have had with HIV from its very existence.
When we look at HIV and we see how we are disproportionately affected, we are only 13% of the US population, yet we consist of more than 50% of the new HIV diagnoses every year. Until we examine those things, HIV is always going to be prevalent within our communities, regardless of the level of access that we have.
Right, we're at the culmination of more than 450 years of systemic oppression. And that systemic oppression sits right at the juncture of sexual and reproductive health rights and justice. So when you talk about HIV and you lift up all of the societal ills that create vulnerability, and at the top of all these measures or indices of vulnerability sit Black people.
When you are part of a community that's either been over-sexualized or demonized because of your sexuality, having something that relieves that anxieties, having something that puts you in control of your sexual health is definitely something we all need access to.
PrEP is a really powerful tool that we have to combat HIV. And really, unless we're able to get PrEP to Black people, it will be impossible to end the HIV epidemic.
I'm grateful this summit was organized to find solutions to the problem of uptake in the Black community.
I think what stood out the most to me today was that people were hungry for this conversation. These are people who are advocates, they're peer navigators, they're PrEP users, they're PrEP navigators. They see what's happening.
And when you look at all those strategies, I'm seeing that we're all coming at it from very different angles. I think that that's a beautiful thing. And I think that that's how we move forward.
I think what really worked well today with the PrEP and Black America Summit is we didn't just come together and brag about the work that each individual or each organization is doing. We didn't just come together to spread awareness. We actually came together to talk about the challenges and the systemic barriers we have to get in the Black community on PrEP.
There is something fundamentally missing with the way the systems of care, treatment, and prevention are set up. They are not set up to serve our people for a various number of reasons that we've described here today.
It really moved me because I've been in the work since 2012, right? And before 2012, but certainly since, PrEP was, first approved, the first drug approved for PrEP. And it never occurred to me that what we were doing today was the first time that this sort of thing had happened before.
Today's meeting was really so important because it was about figuring out the beginning of the roadmap that will allow us to ensure that we have equitable access to PrEP specifically for Black people.
Not enough time to watch it again, but okay, so a few things about the PrEP and Black America Summit. It was several advocates that got together, and we just wanted to address some of those barriers. We didn't initially even set out to have a summit. We just kind of said, we looked at those numbers. We knew we wanted to have an impact in the community, so we tried to figure out what is the next step? How do we bring awareness? How do we address those barriers? And we realized that the conversation was much bigger than just several advocates. So we had to convene Black community stakeholders in Atlanta on September 13th of last year to talk about some of the gaps in PrEP access. So we came together to strategize what a national PrEP program needs to address racial disparities. At the time that we started talking about having a PrEP and Black America Summit was also the same year that the Biden administration in their fiscal year 2023 budget requested funding for a national PrEP program. So mobilizing those advocates to kind of talk about how we can create demand within our community and get our community to support a national PrEP program. And from that, what Leisha talked about, we released the For Us, By Us, PrEP and Black America, a master plan for HIV prevention, which can be found at prepforall.org/PrEP and Black America, which is a report that talks about the discussions and the findings that came out of the first PrEP in Black America Summit. And the next summit will be in 10 days in New Orleans, Louisiana. It's open, it's free to attend in person as well as virtually. So what are those key recommendations that came out of the first summit that was published in the For Us, By Us, PrEP in Black America report? We need to energize the Black HIV prevention health force. We also need to educate the Black masses on the science and effectiveness of PrEP and support a federally funded national PrEP program. So we definitely need to increase Black leadership. We are the experts at addressing the systemic barriers that impact PrEP access in our community. We also need to lead the charge on education and also marketing and to our community as well, so that everybody can understand what PrEP is, how it works, and the systems at play that that can allow us to access the access PrEP as well. Also, we have also there's a national PrEP program working group that was convened by PrEP for All. And they also came up with recommendations for what a national PrEP program should look like. And what's interesting, even though we have overlap on both of those coalitions, they're two separate entities, yet we still have similar recommendations, you know, maybe worded a little differently. We definitely took into account what specifically our community needs, the Black community, but I just found it interesting that there's parallels. So just like we need a national PrEP program to address coverage issues, we want a PrEP pass. What a PrEP pass is a federal reimbursement system that you can use at pharmacies and at laboratories to get all of those necessary things done, that be able to access PrEP, like your blood work, your labs, HIV and STI screenings. And what it would be is just like a pass that you can go online, go on a computer or go on your phone, apply for it, bring it to a pharmacy just like an insurance card, or bring it to a lab just like an insurance card for coverage. We also need provider expansion. So just like we talked about increasing leadership, we also want to increase provider expansion. So one of the ways that we talk about doing that is also within non-clinical settings by leveraging teleprep. So imagine being, if you're in a rural area that may not have competent, and sorry, I don't want to slight rural areas because I know there are great providers everywhere. But we do know that oftentimes people in rural areas may have challenges with accessing PrEP services. But imagine being able to walk into like an LGBTQ center or intimate partner violence shelter and being able to access a provider through telehealth to be able to get a PrEP prescription. So those are just some of the things that we've talked about as well as demand creation. So that's similar, just like we want to be able to educate the masses, we have to be able to do demand creation, because we can create a PrEP pass and we can create a national PrEP program, but if the component of that is not actually educating people on what PrEP is, actually educating people on what services exist to help them access PrEP, ultimately a national PrEP program would be a failure without that component, because we have to make people actually create, we have to create an environment where people actually know about this and are able to access it. So if you want to support a national PrEP program, again, the link is in the chat. There's a QR code on the screen. Tell the CDC that I want my PrEP pass. We want we're asking CDC to create this mechanism, house it within the CDC. That way, because one of the things that we know with like, and don't get me wrong, definitely those medication assistance programs and programs like PrEP DAP are great, but when you have multiple different programs that people have to access and multiple different applications that people have to fill out and different programs that you have to submit different paperwork to, ultimately that can create more barriers and challenges to people trying to access PrEP. But if we have a centralized system where you can go and apply for a PrEP pass, that would definitely create less knock down barriers for people trying to access PrEP who are uninsured or underinsured. And again, there's still time to register both in person and virtually for the PrEP in Black America Summit. That is on May 19th in New Orleans, Louisiana from 10 a.m. to 4 p.m. And if you have any questions, you can email me at michael@prepforall.org.
Thank you so much, Michael. Beautiful job rounding out really a wonderful set of talks this morning. I'm gonna invite folks to raise their hand and ask questions. We now have more than 15 minutes, woohoo, to actually have some more conversation. So much has come up for me. And I look at that. Wakefield has a question. All the way from Seattle, where it is still very early in the morning. Looking good with your morning hair, Wakefield. Go ahead, ask your question.
My question for all of us is not just directed to the presenters, who I really appreciate this morning, but to ask ourselves, when we start talking about equity, have we actually provided equitable educational opportunities for individuals to understand the potential value of PrEP for their own personal health in a manner that addresses them in the cultural context where they are, in places where they have to live with HIV stigma? You know, if we were able to remove all of the barriers today, would there be a change in health-seeking behavior for Black folks with regard to PrEP with what we've done so far?
That is
Jim?
go ahead, please jump in, Leisha.
Wakefield, thank you so much for the question. And I believe my response will be exactly what you are thinking, and the answer is no. We have not done a great job of ensuring that people are educated and aware about PrEP. And I just want to take 30 seconds and give an example. Last year, the Georgia HIV hotline reached out to me about the number of women, mostly in rural communities across Georgia, that was calling into the HIV hotline as it related to PrEP. They all had the same question. And the question was PrEP for women? Now, they only had to go by the commercials that they were seeing, and the commercials were reinforcing that it wasn't. But if there was education and awareness about that, those women would have known, regardless of what they saw in the commercial, that PrEP was an option for them. And so as a part of a national PrEP program, as a part of our both individual and organizational entity work, we have to ensure that we are both raising awareness and education. It seems so simple, but it's so significant to the success of PrEP scale up, especially in Black communities.
And Michael or Patrick, did you want to jump in there with anything else?
No, and just want Leisha explained that great, but no, I was just wanting to add also that I think when you talk about education and medical mistrust, those things tie in together. Often whether we're talking about the COVID vaccine or we're talking about PrEP, I often hear people talk about medical mistrust, racial medical mistrust, which definitely happens, but we also have to talk about people's access to being able to be educated. Are you able to access a provider that is going to explain this in a way that resonates with you? Are you going to have a provider, or are you going to have a not just medical providers, but test counselor or outreach worker who understands why you may have that hesitation, or understands how to talk to you in a way that you'll be able to understand the importance of PrEP? Because I'm definitely, even doing direct service work, and I always let people know I do not have a medical background. I didn't even get good grades in biology, but I know how PrEP works, and seeing young and again, I think this is why it's important to increase Black leadership in these efforts, because when I see a young person who's from the same background as me, who has the same experiences as me, I know how I would want someone to explain PrEP to me if I were 20, 21 years old, never engaging in a healthcare system before. So definitely always making sure that when I'm providing that education, I've definitely had people who would come into the clinic and come into the office and like, oh, I'm not taking any medication. And then by the time we're walking out the room, it's like, so wait, I take it once a day, right? You know, so being able to have those conversations in a way that resonates with our community is very important. So again, I think when you talk about education, increasing Black leadership, and medical mistrust, all of those things tie in together. You can't address one without the other.
Thank you for that, Michael. And I think you're all amazing advocates. And I think one of the superpowers you definitely have is not only do you know your shit, but you know the fact that you're a PrEP user and you've been a PrEP navigator. I know as an advocate myself, I'm neither. I'm positive, so I'll never be a PrEP user, and I've never been a PrEP navigator. So your ability to just speak that truth is just really powerful. And I hope we have more folks like you joining the movement. And so speaking of more folks and joining the movement, you know, I am so moved and so inspired by the PrEP in Black America efforts. And I think it is so incredibly important that it is led by and for Black people. But so many of the problems in this country are due to white people. And so I'm wondering, what are your suggestions, Michael and Leisha, for white allies to be engaged in the PrEP in Black America efforts? What can we do to be most supportive to you and most helpful in your efforts as you lead and guide us to equity and justice?
Well, Jim, I think that you already just said the key word, and that's allyship. And I want to give you just an example of that in real time. The fact that you're having this webinar and included Michael and I to this space to help both promote and raise awareness of the needs for PrEP within Black communities in a framing of what Black people are saying, this is what it's going to take. To me, that's allyship at its finest. You have a space that you felt was important enough, right, to include us as your partner in this conversation on today. And so for those who are under the sound of my voice that are asking themselves the same question, because that was the ask today, to look at the information presented through an individual lens. What can I do? Some of you also have spaces that is an opportunity for presenters like Michael to come in and talk about what communities are already saying. Some of you have influence and have privilege and relationships with CDC and with policymakers and those individuals that I may never get invited to a table to have a conversation, but you get to make a phone call and things happen. And so I want to leave this to give Michael space. And I say this in love. And so I do hope that it's not offensive, but Black people don't need a savior. We need opportunities to implement.
Wait, hold on. My clap it. I got to clap. I want to clap here.
But we hear you clapping, Eve. Yes, we do.
Oh, I'm sorry.
That's okay. That's okay.
I didn't know you could hear me.
That's okay.
It's okay. So obviously I'm in the right house and I'm saying the right things for your comment. But there are opportunities that are needed that to be able to raise our own issues and raise our own solutions. And so that's what allyship does for me. There are going to be times that even we're talking about Black communities that I show up as an ally, especially when we're talking about Black same gender loving men. And then what becomes my role now as an ally? to ensure that that message and that those needs get addressed.
Michael, you want to jump in?
Yes, definitely to answer that question. I just dropped in the chat an article. I want to shout out Danielle Campbell, MPH, one of the organizers for the PrEP in Black America Summit, and who definitely took the lead on pulling together our For Us By Us report. And in that interview, one of the things she talks about is the face of the epidemic has changed and leadership has to change with that. So as we talk about just as Leisha said, giving us, definitely providing opportunities. I think even within our organizations, learning when to pass the baton, how to pass the baton, and also, definitely, one of the things I love that Danielle said is that it doesn't take away from the years of experience that people who have founded these historically successful organizations, but now is, it doesn't take away from their leadership and their experience and what they've brought to the field, but are you passing that on? So are you teaching, do you have someone in your organization, a young Black person who might be a outreach worker? Are you teaching them how to write a grant? Are you teaching them how to evaluate a program? Are you teaching those skills that they will need to be able to take advantage of those opportunities and grow? And definitely, I love being on panels. I love talking, but also if we're going to invest in putting people on panels, are we going to invest in their professional development so that they can take, when a baton is passed, they are ready to take charge and make significant change in an HIV epidemic as well? Because unfortunately, we can't panel discussion our way out of it. We have to be able to develop the skills and take charge of the leadership as well. Take charge in leadership as well.
Oh my God, so beautifully put. We cannot panel discussion our way out of this. And so many other quotable quotes here today. Thank you so much for that pearl of wisdom. Now, I know Evelyn, my good colleague here in Chicago at the health department, was getting very excited and jumped in. And I know you also want to say something. It sounds like you maybe you're in your car or something, Evelyn, but
No,
go
I'm
ahead.
actually in the office, but I could not find I am so sorry. I didn't mean to shout out like that. I thought I was
No, it's
on mute.
okay.
I
It's okay.
apologize. I'm not
Totally
in
fine.
church. I'm shouting out like I'm in church over here. So I have so many things I want to say. I want to thank you, the panel, and you too, Jim, but thank you especially to this panel. You've brought out some wonderful points and really relevant information that hopefully others will have an opportunity to listen to. And I love this For Us By Us model. I think it's a powerful model for all services, interventions, prevention, anything as a strategy for Black people. And we have to remember, we don't have to remember, the non-Black people have to remember that they need to relinquish, some power and allow the Black community to have these models that are run for us and by us. But I also wanted to say that the offenses and the atrocities that have occurred are not just historical in terms of many, many years ago. You could just look to what happened to grandma yesterday and note that these are things that are still occurring. So we have to, I think, start, as you said, educating not just our consumers, but our providers, and talk about things in a historical context, but also make sure people know that this is still relevant today. I heard our medical director, who's Asian American. I know this month is Asian American month, and she quoted this, and it is so true, that there is no path to equity without walking through history. And that's a truth. Because we use Sankofa. In the Black community, we say Sankofa, looking back in order to move forward. But we have to also look at the here and now and recognize that these same offenses are here today. And educate our youth about it, educate our allies about it, and say no more. This has to end. So thank you all for what you're doing and what you're saying. And I love the resources that you've shared, and I will be looking at those and hopefully have an opportunity to meet you in person at some point. Thank you.
Thank you so much, Evelyn, from the Chicago Department of Public Health here in the beautiful Windy City. We are now in our last minutes I know there's so much more for all of us to say, but I'm going to go around to each of the speakers and have you each give us one parting nugget to take with us. So we'll all have 3 big juicy nuggets to carry with us today through the rest of the week and the year. And I'm going to go in reverse order of how the presenters presented. So we're going to start with Michael, then Leisha, smack dab in the middle of that tasty sandwich, and then Patrick. Michael, first you.
Yeah, so just want to add one last thing. And again, I'm borrowing from our co-organizer, Danielle Campbell, as she said, in addition to like making sure that we're doing development, also make sure we're funding Black people to do the work. So make sure that when we're ready to do the next PrEP in Black America Summit or put out the next publication, like make sure that Black people who are taking charge and leading the work, that you are funding the research, funding the smaller community-based organizations, and funding these initiatives and marketing campaigns so that we can reach our community, because money talks, and that's definitely what our community needs. So.
That's right, and good wishes and thank yous do not pay the bills. We need money behind our good work and for our expertise and wisdom and effort. Leisha, your nugget to take with.
First, ditto to what Michael said. But I also just want to be just both the reminder and the encourager that I believe we're all here for the same goal. And that is to get to the end of this epidemic. And the road that we travel might look a little differently, but let's stay focused on the end destination. And that means that we all play a role, we all are accountable, and sometimes it means helping to uplift someone by taking a step back to ensure that we get there together.
Thank you as ever, Leisha. So beautifully put. And Patrick.
I really appreciate everything that I've heard today and the contributions of everyone on the call. I think, you know, we're working in an inequitable system, and we are not going to get the outcomes that we want for our communities if we don't have equity, and we're not going to have equity if we don't have justice. So I'll come back, Jim, to your bigger tent, that the problems that people are articulating with and dealing with in our own communities are going to be served best if we can move towards justice, and equity can follow. So I appreciate the leadership of my colleagues and the chance to be a part of this today.
Thank you, Patrick. That is a lovely way to wrap things up. So thank you. Thank you, Leisha. Thank you, Michael, for joining us here today and for sharing your thoughts and your wisdom, and for all the good work that you have been doing and all the good work that you're going to do. Thank you to the great questions that have come up in the chat. Thank you, Wakefield, for coming on camera from Seattle, where it's still, I don't know, 2 or 3 in the morning. It's early there still. So thank you for that. Thank you for joining the this Choice Agenda webinar. I hope to see you at Prep That Booty the end of June. I hope to see you on our global discussion list if you aren't there already. As we mentioned, this has been recorded. You will get a follow-up email. Hopefully you'll get that follow-up email. Sometimes you need to check your spam folder, but that email will let you know when those things are available. But you can go and check that website anytime. All of our previous webinar recordings and slides and resource documents are there for you to peruse. And we typically get these things posted really quickly, thanks to the amazing work of our comms department at AVAC. And I'm going to shout out Jason in particular, Jason Rosenberg, who really helps me make this train run on time and deal with all the things. So thank you, Jason, and the rest of the comms team at AVAC. Thank you to everyone who showed up today. Thank you to all the folks who are going to listen to this at another time, because this time was not convenient. And with that said, I'm going to send you all onward. Have a wonderful day, evening, tomorrow. And I hope to see you online and maybe even in person soon. Take good care and bye-bye.